Hello, everybody, and welcome to this new edition of the Journal Club of the EASD Early Career Academy. My name is Caterina Conte. I'm one of the committee members, and today we have the pleasure to have here Ditte Smed Kornum from Aarhus University. She's a PhD student, an MD, and she is the co-first author of a very interesting paper, very interesting study that she will present today. And the study is, the title of the study is Transcutaneous Vagal Nerve Stimulation for Treating Gastrointestinal Symptoms in Individuals with Diabetes. Randomized, double-blind, sham-controlled, multicentre trial. So it's a lot of stuff. So Ditte, thank you for being here today. And I'm co-chairing with my colleague from the EASD Academy, Jan Goida. So Ditte, the floor is yours. And please, you can share your screen and tell us something more about this very interesting study.
Okay, and you can see my screen now?
Yes.
Perfect. So first of all, thank you very much for the introduction and for inviting me to present our results for you all today. I'm very grateful for this opportunity, so thank you very much. As said, my name is Ditte, and I'm a PhD student and a medical doctor at the Department of Hepatology and Gastroenterology at Aarhus University Hospital in Denmark. Furthermore, I'm affiliated with the Steno Diabetes Center in Aarhus and with Aarhus University. For the study I'm presenting for you today, we have investigated the efficacy of transcutaneous vagal nerve stimulation for treating gastrointestinal symptoms in individuals with diabetes. Funding from the Novo Nordisk Foundation made this study possible. So the study was conducted across 3 Steno Diabetes centers in Denmark. And Philip, Asbjørn, and Claus were the primary investigators, while Christina was the sponsor of the study. David, Huda, and I were the 3 PhD students who conducted the trial, and we were each responsible for 1 investigational site. So this was a very large trial. So first of all, I'd like to provide a very large credit to all my co-workers and the research personnel, and of course, all the study participants helping us with this study. I'll start by introducing this condition called diabetic gastroenteropathy. Autonomic neuropathy is a common and often severe complication of diabetes, and it affects several organs within the body. When it affects the gastrointestinal system, neuropathy can be seen in both the enteric nervous system, but also in the regulatory autonomic nerves connecting the brain and the gut, and this includes the vagal nerves. When this neuropathy occurs, motility disturbances can be seen throughout the entire gastrointestinal tract, and this may cause severe gastrointestinal symptoms, malnutrition, poor glycemic control, and unpredictable drug absorption. And this may reduce the quality of life and also significantly increasing the burden of having diabetes. Dietary changes and blood glucose control are often the initial treatment of this condition. Pharmacological treatment, where you often use prokinetic drugs, may have limited effects, and they can provide severe side effects as well. Surgery may be an option in severely ill patients with diabetic gastroparesis, but these are invasive procedures which carry a risk of complications. So there is an unmet need for new, effectful, and non-invasive treatment options. A potential target for these treatments could be the vagal nerves, as this bidirectional signaling between the brain, the brainstem, and the gut are essential for maintaining this normal gastrointestinal function, as mentioned before. And this device, called the gammaCore, is a cervical vagal nerve stimulator, which stimulates the cervical part of the vagal nerves. This invasive device is a gastric electrical stimulator, and it is shown to reduce gastrointestinal symptoms in individuals with severe diabetic gastroparesis. However, it does not improve the gastric emptying time, so it is believed to work by stimulating the afferent vagal nerve fibers to the brain and brainstem, and therefore changing the processing of these incoming signal from the gastrointestinal tract. And likewise, as the invasive device, this transcutaneous stimulation are thought to increase the signaling in these afferent vagal nerves as well. It is shown in studies that it changes the signaling in the brain by EEG measures and MR measures, changes the signal in vagal-related areas of the brain, and that it can moderate the gastric and gastrointestinal motility when using this device. Therefore, it could be a possibility that it also reduces gastrointestinal symptoms. It is registered and CE marked for treating as an adjuvant treatment for treating primary headaches and epilepsy. So now to the aims and methods for this study. First of all, our aims were to assess the efficacy of transcutaneous vagal nerve stimulation regarding gastrointestinal symptoms and transit times, and cardiovascular autonomic measures when investigating individuals with type 1 or type 2 diabetes. The intervention were, as said, this device called the GammaCore, which is handheld and self-administered by the patient or participant using the device, and it provides a low voltage electrical signal at a frequency of 5 kilohertz, and each stimulation in one part of the neck takes 2 minutes, and on the other part also 2 minutes. So 4 minutes for every treatment. So we conducted a randomized double-blind sham-controlled multicenter study and investigated 131 individuals with either type 1 or type 2 diabetes, gastrointestinal symptoms or signs of autonomic neuropathy. These individuals were randomized 1-to-1 to receive either active vagal nerve stimulation, seen as the black arrows up here, or sham stimulation, seen as the blue arrows in the bottom. The study were divided in 2 study periods. This over here represents study period 1, and this evaluates the effects of 1 week of intensive vagal nerve stimulation 4 times a day for 1 week. And this study period over here evaluates the effect of 2 daily stimulation for 8 weeks. Primary and secondary outcomes were assessed before and after each study period. And now to the outcomes. The primary outcomes were assessed gastrointestinal symptoms, and this were assessed with 2 validated questionnaires, one assessing upper gastrointestinal symptoms, the gastroparesis cardinal symptom index, and one assessing the overall gastrointestinal symptoms with the gastrointestinal symptom rating scale. Secondary outcomes were assessed gastrointestinal transit times, assessed with the wireless motility capsule, and cardiovascular autonomic measures, which were assessed with cardiovascular reflex test using the Vagus device, or cardiac vagal tone assessing the using the emotion files device. And now to the results. Yeah, so we included 63 participants in the active group and 68 participants in the sham group, and they were overall comparable regarding demographic and clinical characteristics. Down here, I have presented the autonomic characteristics of the groups, and they were included in the study using this questionnaire called the Compass 31, or this cardiovascular autonomic neuropathy score using the Vagus device. And we can see that above 85% in each group had autonomic neuropathy assessed with the questionnaire, and above 50% in each group had cardiovascular autonomic neuropathy in the active group here and the sham group over here. Now for compliance, and this is the results from study period 1 and study period 2 over here. The purple line is the sham group, and the black line is the treated, the active stimulated group. And we can see that compliance is above 85% overall in both study period, except for the last week in study period 2, where there were some logistical issues, and therefore the compliance seems lower. This is the primary result from study period 1, assessing gastrointestinal symptoms. This figure over here are the gastroparesis cardinal symptom index. and the figure over here is the gastrointestinal symptom rating scale. These are the data for the active stimulated group, and these are the data for the sham stimulated group. And it is symptom scores from the questionnaire. All these points here represents the symptom scores before the stimulation, and this over here is the symptom scores after the stimulation, and the thicker line represents the mean value for the group. And we can see that there is a minor symptom decrease across the stimulation period, but it is comparable to the sham group. And it is seen both for this questionnaire and for the questionnaire over here. Now we are looking at the result from study period 2, and it's quite the same results. There is a minor symptom decrease in the active group, but it's comparable to the sham group. And it's seen for both questionnaires as well. Then we did several sub-analyses to further look into these results regarding gastrointestinal symptoms. And we analyzed symptom subscores in each questionnaire, comparing the two groups. We also did a multivariate linear regression analysis where we adjusted for several covariates, also comparing the two groups. Then we looked at participants, only those with a compliance above 80%, and we did analysis of participants with a high symptomatic burden at baseline, as these participants maybe would easily reduce their symptoms compared to those with a lower symptomatic burden at baseline. But regardless of these analyses, we could not show any difference between the groups when looking into gastrointestinal symptoms. This is the result from the secondary outcomes regarding gastrointestinal transit times. This is the gastric emptying time, the small bowel transit time, and the colonic transit time. Looking for the small bowel and the colon, this is the same, well, as for the symptoms, that we could not see any difference between the groups. When we looked at gastric emptying time, we did see, well, the result was significant, but it was a minor difference, and it was actually opposite of what we would have expected if we had seen a difference in this gastric emptying time, that the gastric emptying time were reduced a little bit more in the sham group when compared to the active group. I will not show the results from the cardiovascular autonomic measures, but there were no difference in regarding of any of the two autonomic measures. Neither for study period 1 or study period 2 when comparing the active and the sham group. So in conclusion, transcutaneous vagal nerve stimulation as compared to sham stimulation does not improve gastrointestinal symptoms, transit times, or cardiovascular autonomic measures among individuals with diabetes, gastrointestinal symptoms, and symptoms or signs of autonomic neuropathy. So we are concluding that transcutaneous cervical vagal nerve stimulation will not likely be a recommended adjuvant treatment in these individuals. So thank you very much for listening, and please feel free to ask any questions.
Ditte, thank you very much for a nice presentation. I must appreciate that it was a very cumbersome work that you've undertaken. And I congratulate you to the results, even though they are negative. But I appreciate that we can eventually see also negative results to be published, which is great. We usually ask 2 sets of questions, so I will start with the question that comes to my mind concerning the study design. And maybe I think that later on we will proceed to some career development questions, which are definitely burning for our early career academy members. Well, seeing the negative results, the first thing that comes up my mind is that whether in the way we selected the population and we stratified the population based on the presence of the gastric symptoms or not, whether we use the right tools, and also whether we, concerning the randomization and the sham procedure. So what I would like to ask you is how you actually maintained the sham procedure in the right way that the patients are not aware whether they are treated or shammed in the end.
Yeah, thank you. That's an important limitation of the study. It is the sham device, because in this study we used a sham device which did not contain any electrical current. So when you have the two devices besides each other, you cannot see any difference. But if you try both devices at the same time, you certainly can feel a difference. And when you use the active device, it's like it makes some muscular twitching, and the mouth is like pulled a little bit when you use it, and you can feel it on the neck as well. When you use the sham device, it's only like a humming sound. So it was very important to us that, first of all, the participant, they do not know how an active stimulation feels, because this is not a broad treatment, and it's not like used at many other purposes, especially not in Denmark. So that's the first thing. And then the second thing is that we use this parallel group design, so that each individual use the same device all through the study in both study periods, because they would be unblinded if they had one treatment in the one study period and the other in the other study period. That would certainly unblind the participant. So yeah, that was the other thing. And then we had the unblinded personnel who were the one instructed the participant in how to use the device, because if I saw how it was used, then I would know what treatment they had. So I was not involved in any of that at all. So, and of course, it's a limitation that it's only a humming sound, but it would also be very difficult if it provided some current, because then we would not know if this current could actually stimulate the vagal nerve, and then it would maybe limit the difference between the groups, and maybe the sham group would actually have some kind of effects, and it could not be seen what was the difference regarding that. So there was a lot of thing we discussed beforehand and before choosing this sham device, but it is a limitation of the study.
Yes, great. Thanks a lot.
So these devices are licensed for the treatment of migraine, and I suppose people, well, they were tested in people with migraine and general people with migraine, and maybe they don't have metabolic alterations. So do you think the fact that this treatment was not effective might depend on some damage related to hyperglycemia? I saw in the study that patients had an HbA1c at about 8%, so glucose control, glycemic control was not optimal. So, and of course they had gastroparesis, so they had neuropathy. So do you think maybe you needed, I don't know, a different treatment scheme? Maybe, I don't know how, and also the other question is, how did you come up with this pattern of treatment, like high intensity 4 times a day for 1 week? And then how did you decide how frequently and for how long to treat these people?
Yeah, well, for your first question, I believe it could be very well be the reason for that it's not effectful, because we know that these individuals are not only having neuropathy within the gastrointestinal tract, but also in the brain and in the brain stem. So, and their registration of visible symptoms are not as good as people without diabetes and neuropathy. So some with very severe diabetic gastroenteropathy can have fewer symptoms because they do not observe the symptoms as other people do. So yeah, that could be a reason why we can't stimulate the vagal nerves as sufficiently as we hoped for, because it simply doesn't work as we believed. We did a pilot study, though in healthy participants, and we saw that we could change heart rate variability measures in these individuals, but we could not do it in our individuals with diabetes. So I think it maybe underlines this point that this could be the reason. Yeah. And your second question to how we designed the study. Yeah, first of all, when used in individuals with migraine, it could both be as preventive or for headache episodes or attacks, and it could be for the acute attack, they could stimulate. And in these individuals, it is recommended from the firm that it's used twice a day as a prolonged treatment, and the same stimulation period with 2 minutes on each side. So that was the main reason for using this dose in the long-term study. But yeah, we have discussed it a lot on for how long they should be treated. And it seems maybe as a little too low a dose, especially because they have these neuropathy changes in their nerves. So, but still, it's not that feasible to ask individuals to treat or to conduct this treatment for 8 weeks, more than 2 times a day. So if we were supposed to use this device, I think it's about the maximum time that they would actually have keep a high compliance. Yeah, I hope that answers your question.
Yeah, meaning lower sensitivity to the stimulation, right? That's what you implied.
Yeah.
Okay, Katerina, if there are no other questions concerning
I have
the
just
study results. Yeah, let's go.
One last curiosity about because I think it's very fascinating. This is a developing field, and I think it's very fascinating. So vagal nerve also is involved in metabolic control. So did you observe? So this is a different outcome. Did you observe any changes in glycemic control over 8 weeks in the long-term period, or did you look at that?
Yeah, we looked at it. They all had a Freestyle Libre sensor connected both in the first and the second study period. We did not include it in this part of the study because one of my co-workers, she's writing that article. But overall, we could not see any difference in glycemic control. That's the short conclusion. Yeah. Yeah.
Thank you.
Thank you.
Okay. So, well, if I may,
yeah.
I mean, great results. Thanks a lot, and it's really fascinating thing, and I would not be surprised to hear much more about it in the future. But being myself a clinical researcher, I know that sometimes it's a unrewarding task. That on one hand you're not the right clinician and you're lazy doing some research, and on the other hand you're not the right researcher because you do not understand all the lab stuff that is going on in the wet lab. So I wanted to ask you how you manage yourself and how did you manage to protect your time so that you could really supervise, conduct, and follow up on the clinical trial that is a multicentric, amazing trial on this procedure. So give us some tips. That was the question.
Well, first of all, I just feel very lucky because I have had these 3 years where I haven't been in the clinic. So I have had 3 years leave for doing my PhD. And it's just been, well, truly amazing having the time to be a little more nerdy and, dig deeper into these kind of things. And this is just a very interesting group of patients. And I'm just very motivated for helping them because they do not have many treatment options. And that's my clinical background talking there, because then it's providing me motivation for doing this research, because I know that it could be usable in the future for these individuals. But yeah, 3 years off from the clinic has been, truly amazing for, doing the research, I believe. Yeah.
I am also a clinician, and during my residency, I spent 18 months abroad to do research. But when I went back, I had forgotten some of my clinical skills. So what's your plan for the future? Do you think you will be a physician scientist or just focus on research? Or what's your plan for the future? What's your ambition? What do you want to do?
I have some kind of fear of that as well, but hopefully it's like riding a bike. So it's in there somehow, and I can find it again and get my clinical skills back. I certainly hope so. Hope so. But right now, it's just we have so many interesting projects coming on. So I'm just not really ready to let go of this field of research. So I'm really hoping for that I can be employed as a postdoc. We have one project that we are hoping to get funded to do, and if that will happen, then I'll be employed as a postdoc for 2 years more. So we can do and finish up these very interesting studies, and then I believe afterwards I'll go back to being a clinician. That's my plan, and hopefully, employ some of these results we have seen in the clinic. Yeah.
Then good luck for getting into the postdoc position.
So the protected research time is something that, from what you said, seems to me the most important thing that made you realize or conduct such a trial in the end. So that's an important point. Well, I have no more questions from my side. Katrina, do you have any more questions?
Well, just a curiosity, because younger people, especially physicians now, I think not so many are enthusiastic about research. They would just go for the clinical practice. So what ignited your passion? How did you decide to get into a PhD program after your MD studies?
That's a very good question. I think it was the project. I have during my medical school, I had 1 year a 1 year leave there as well, where I studied in diabetes and pregnancy, so another subject, but still diabetes. And then this project came along, and it was just, I have an excellent main supervisor, and I have heard very many good things about him. So a project that I thought was very motivating, and then a good research group around me. I was just motivated by that, I think.
Good. That's good. So having someone who can inspire you is very important.
Exactly, yeah.
So let me thank you once more for presenting us your paper and your work, and also your career path. With that, I would like to close up the session that we had. Thanks everybody for watching us. Thank Ditte for being with us today. And before we close up completely, let me just very briefly tell you a few words about the EASD Early Career Academy, which is a body within the EASD that is here for early career researchers to start up their careers and help them being part of this amazing European and global diabetes society that is here to empower research, empower their career, and also have some fun and keep their curiosity on, if I would use this this word, which I heard quite often today. So having said that, if there is no other burning things to say, which seems to be that not, so I would like to thank our auditorium and all of you to join us today, and wish you a nice rest of the day.